And so this is supposed to be a basic talk, so I'm going to keep it really basic also. So beyond just the anterior tibial, the posterior tibial, and the peroneal artery, obviously the anterior tibial feeding the anterior circulation, and the posterior tibial, the posterior circulation, we talk about in a second. The peroneal artery has its branches. The importance of the anatomy here really comes into the issue of direct versus indirect revascularization, because understanding these relationships and what feeds what and what territory, that becomes very important in your strategy of revascularization in patients with critical limb ischemia. Now, we don't always have the luxury of revascularizing the territory that we want. For example, in this case of the posterior tibial artery occluded, we may or may not be able to recanalize the posterior tibial artery, which is good to know that the communicating branch is there, which also supplies the posterior circulation, but also the peroneal also has a calcaneal branch. Now, that happens to be more on the lateral side and the medial side of the calcaneus. Nevertheless, within the calcaneus itself, there are plenty of communications. So a patient that comes in with a calcaneal lesion that the posterior tibial artery cannot be recanalized, this has got to be your target. You have to go after this, and hopefully they will have a calcaneal branch that would be helpful. So we're going to limit the discussion around those types of discussions. All right, so perforating branch goes into the anterior tibial artery. Communicating branches, we talked about it usually up here. It goes into the posterior tibial artery. It's also a good collateral pathway for recanalization of the posterior tibial artery. If you can't do it antegrade, sometimes we try this path before I stick the posterior tibial artery in a patient with critical limb ischemia. And then the calcaneal branch, as I mentioned, is from the peroneal artery is mostly lateral, and from the plantar artery is mostly medial. So here's the, again, lateral branch and the perforating branch and the anterior tibial artery, as we talked about. This anatomy is, there are variations in this anatomy that would play a role in patients with critical limb ischemia, so you have to be aware of these connections. This is a very nice review article by Marco Manzi that he talks about the anatomy of the arteries of the foot in relation to revascularization, direct versus indirect. So it's actually a good thing to know. Anterior tibial artery, dorsalis pedis, and these are the branches that typically feed this territory over here. The blood supply to the first digit is usually variable. It could be from multiple sources, and most of the variation of the anatomy in the foot is actually revolved around the supply of the toe. And the posterior circulation here is what the supply is, and medial calcaneal branch, which goes on the medial part of the calcaneus, and the plantar artery is lateral and medial. And here's the typical sort of nice picture. It's been a long time since I've seen an angiogram of the foot that looks like that, but nevertheless, it's nice to find it every once in a while. That here's the lateral, plantar typically, and medial plantar, and the dorsalis pedis. And sometimes the dorsalis pedis, one of the variations that the dorsalis pedis may not always be present or maybe diseased, and then the lateral tarsal takes over, that in a lateral projection looks like a dorsalis pedis. And so make sure that that is not that mistake is not made. And in this location, right in the first metatarsal space, is where the dorsalis pedis dives down and forms the pedal loop, the plantar loop, and communicates with the lateral plantar artery, which in this case is that one over here. And they feed the metatarsals, so on and so forth. So the basic anatomy, so now there are two loops, there are two sort of pedal loops in the foot. One is the more proximal one, which is referred to as deep pedal arch. It goes by various names. And then the more typical one that people talk about plantar arch or pedal plantar loop, is the more distal one, which is the one we just talked about, when the dorsalis pedis dives down in the first metatarsal space and connects to the lateral plantar artery. Now, when that is diseased, this is a good backup. This is not always present. And this particular loop, the deep pedal arch, is particularly difficult to cannulate in most patients and dilate. But be aware that this could be a secondary supply to the foot when other options fail. Here are some examples of the typical patients you may see. So as you can see in this case, at the posterior tibial artery, let's say this patient has a calcaneal lesion and you wanted that to heal. Peroneal artery would be a good secondary supply to it if you cannot connect the posterior tibial artery to the plantar arteries down here, which is not unusual in patients with renal failure. But keep also in mind that there is a lesion right down here that could be tricky to treat, so this would be our secondary path. And this is the same patient in the AP projection. Here's a different patient. That anterior tibial artery, dorsal pedis artery were actually occluded. This is post-recanalization. As you can see, the flow is good just to the point that we ballooned it, and then it sort of drops out, and you go into these small pedal arch. These are the types that have been advocated mostly by our European colleagues, and correctly so, that this flow in this loop has to be established and look more robust. I just caution you that this is probably not the, you want to have good experience before you go into these things because it could easily be mucked up. Again, on the anatomy, here's a variant where, as you can see, the pedal loop does not exist. Not because it's diseased, but it just does not exist. But you have plenty of supply from the others. As you can see, the toes and the heel are very nicely supplied, but there's no pedal arch. Those variants do exist. Now, one of the issues that remember in the proximal trifurcation, if you want to see the origins of these vessels and whether they're diseased or not, they frequently are, is that you have to go to the ipsilateral medial oblique to see these branches. If you go into a projection that most people do to separate the tibia and the fibula, you probably will miss some of the lesions at the origins of these. And then about the mid-level of the leg, the peroneal artery and the anterior tibial artery usually overlap when you are separating the bones from each other. Here are the variations of the tibial arteries above the ankle. Most of it has to do with the origin of the anterior tibial artery. Beware that sometimes there is and I'll show you an angiogram, it's not in here, but sometimes there's actually true trifurcation, that the popliteal artery comes in and there's 3 vessels that take off at the same level. And if that is disease, that's the sort of thing that you need to be aware of ahead of time. Also, in this situation, sometimes it takes off way up here. And if your popliteal artery is diseased, you have to be cognizant of the fact that the anterior tibial artery origin may be high. And so you have to follow all of those in your angiogram down below. Here's a patient. There are some variations that sometimes are actually, here's the variation where all 3 of them take off at the same time. Most of the variations have to do with the length of the tibio-peroneal trunk. Sometimes longer, sometimes shorter, things of that sort. In this case, the anterior tibial artery takeoff is actually above the knee, and they sometimes rotate around each other. So that was most of the issues that we wanted to talk about, and that plays into the next talk that would be on direct versus indirect revascularization. Thank you very much.